Okay, now while that last little presentation is uploading or trying to upload, I just continued on so I can wrap this up because I am really cross-eyed and tired. Um, Speech comprehension and language deficit are most difficult problem for patient and family. Speech therapists can assess and formulate a plan to support communication, and it is also vitally important that we teach the caregiver and family communication strategies. I'm sorry. So next is continuing with the objective data that we use, or maybe no, this might be some subjective how we use the sensory perceptual. But anyway, with the next slide, I want to forget to change the slide. I get to talking and forget to change the slide because I'm tired. I'm gonna quit saying it because when you say it, that make you feel even worse. Lord, don't let me say it no more. Sensory perceptual problems are common in stroke patients. Visual problems influence safety and ability to be independent. And you guys remember, safety is your middle name. If you can't remember nothing, you pick the answer that's got safety in it, because it's always about being safe, and that's what NCLEX is testing you about. Diplopia is often treated with an eye patch, and if the corneal reflex is absent, the patient is at risk for corneal abrasion and should be observed closely and protected against any eye injuries. So as you can see, that list of visual problems, that diplopia, which we already said, that's double vision, loss of the corneal reflex, and ptosis, where we have drooping of that eye, and that homonymous hemaniopia. I wish I could say that like Laura Gaspari. She make it sound so easy, but it is not. That is like trying to say Peter Piper picked the peppers. Oh, I'm a little loopy, y'all. I'm sorry. I'm trying to get through this, but anyway, we're gonna go to the next slide. Again, continuing with sensory perceptual alterations. Um, the patient with a right brain stroke, which will have left hemiplegia, that person is at higher risk for injury because of mobility difficulties. Tasks should be broken down to simple steps for ease of understanding. Environmental control, such as removing clutter and obstacles and using good lighting, aids in concentration and safer mobility. Patients with the stroke on the right side of the brain usually have difficulty in judging position, distance, and rate of movement. These patients are often impulsive and impatient and tend to deny problems related to their stroke. They may fail to correlate spatial perceptual problems with the inability to perform activities such as guiding a wheelchair through the doorway. The patient with a right brain stroke, again, that is left hemiplegia, is at higher risk for injury because of those mobility difficulties. Directions for activities are best given verbally for them to better comprehend, and the task should be broken down to simple steps, again, for ease of understanding. And again, talking about environmental control, we just talked about that, removing clutter and obstacles, using good lighting, provide non-slip stop socks at all times. And you know our patients in the hospital that's high risk for fall, we got the little yellow footies with the little rubber stuff under the bottom. So I'm thinking those the kind of footwear that they talking about. One-sided neglect is common for people with right brain stroke. So we may have to assist or remind the patient to dress the weak or paralyzed side or shave the forgotten side of the face. Patients with the stroke on the left side of the brain, that is right hemiplegia, they commonly are slower in organization and performance of tasks. They tend to have impaired spatial discrimination, and these patients usually admit to deficits and have a fearful, anxious response to their stroke. Their behaviors are slow and cautious, and nonverbal cues and instructions are helpful for them to comprehend. And that is not uncommon in patients who have had a left brain stroke. They need nonverbal cues and instructions in order for them to comprehend. Coping. A stroke is usually a sudden, extremely stressful event for the patient, caregiver, family, and significant others. Reactions to this threat vary considerably, but may involve fear, apprehension, denial of the severity of the stroke, depression, anger, and even sorrow. During the acute phase of caring for the stroke patient, caregiver, and family, nursing interventions are designed to facilitate coping, and it involves providing information and emotional support. And it says here, often a family disease, and it affects the family emotionally, socially, as well as financially. And changing roles and responsibility can weigh heavily on caregivers and family members. So, let me see that I get ahead of myself here. No, okay. The next, I got a slide, but I'm missing my notes. Well, with coping, before I go to this slide that's showing, because I have notes that I don't have a slide for. With coping, we want to explain what has happened, give the diagnosis and therapeutic procedures. When they have to have them, it should be clear and understood by the patient, and we have to repeat and reinforce information as needed. Decision making and upholding the patient's wishes during this challenging time are of utmost importance, and advanced directives should be honored, and family meetings or updates should be held daily about feeding tube placement or tracheotomy if that is the best for the patient at that time, knowing that you don't have to have a feeding tube forever, nor do you have to have a tracheotomy forever. However, they do put those things in until you get better. And that's one of the things that Kindred specializes in is decannulation. People come in there on a ventilator and they have a protocol and they slowly will wean those people off the vent. Then they be on a high humidity trach collar. Then they'll give them a passing mural valve to try to get their voice back. And the ultimate goal is that they decannulate the patient. They put a Band-Aid over the tracheotomy site. And within about 3 days, it is closed up and they are practically back to normal. So it's important that we provide for these patients, and that the family members understand, because they are extremely anxious and they get upset, especially during the acute phase of the disease process. And they'll show that. So in coping, the patient's family should be given careful, detailed explanations of what has happened to the family. Family members usually have not had time to prepare for the illness, and a lot of times we may have to do a referral to social service for these people as well. The patient is usually discharged from the acute care setting to home, intermediate or long-term care facility, or rehab facility. And what's a critical factor in them being able to go to a rehab facility is that they are able to perform activities of daily living independently. Ongoing rehabilitation is essential to maximize the patient's abilities. So ideally, discharge planning with the patient and caregiver starts early in the hospitalization period, and it promotes a smoother transition from one care setting to another. Rehab requires a team approach, so the patient and family can benefit from the combined expertise, care of the actual stroke team. A critical factor in discharge planning, though, is the patient's level of independence, again, in being able to perform those activities of daily living. In ambulatory care, total care is considered in the discharge planning. We have to look at the medications, nutrition, the mobility of the patient, exercises, hygiene, toileting. All that has to be looked at, and some solution we have to be to come to some solution for that patient before they can get discharged as to how they are going to continue in life at the level at which they are, and yet have the best possible life that they could have. So follow-up care is planned, and it is utilized to permit continual nursing. They have to have physical and occupational and speech therapy, and in addition to medical care, because although they had a stroke, they still gotta have their hypertension taken care of. They still gotta have the diabetes managed. So they have to have medical care still as well. Now, community resources, they should be identified to provide recreational activities, group support, spiritual assistance, respite care, adult daycare, and home assistance based on the individual patient's needs. And that's important, especially if you have a person a patient that has survived the stroke, but now they're in a position where they totally have to depend on somebody else to give them a bath, change their bed, put their clothes on, brush their teeth. That can be pretty depressing when you have a stroke and end up in a state like that. It's depressing for the person that the stroke happened to, as well as to the person that has to take care of the person that had the stroke. So that's why I keep mentioning that we have to talk to and provide resources, not just for the patient, but for the caregiver and the family, because this is just as hard on them as it is on the patient that had the stroke. So our rehabilitation with these patients is a process of maximizing the patient's capabilities and resources to promote optimal functioning. And when we're talking about optimal functioning, we're talking about their physical, mental, and social well-being. And goals are set mutually by the patient, family, nurse, stroke, and rehab team. The goals of rehabilitation are to prevent deformity and maintain and improve function. Most patients recover in the first 6 months following a stroke, with maximum benefit 1 year after the stroke. The stroke interprofessional team is composed of many members. They include the nurses, the doctors, the psychiatrists, the physical therapy, occupational therapy, speech therapy, dietitian, respiratory therapy, vocal therapists, all of these people, the chaplain, the pharmacist, the psychologist, the social worker, all of these people are just like in the spinal cord injury person that we was talking about. The same thing with the stroke. The spinal cord injury person practically got the same team with the same team members, because that too is just a debilitating disease, and it is difficult to accept that when you have ended up being paralyzed due to some trauma or what have you, and these people have been paralyzed due to uncontrolled hypertension that has led them to having a stroke. So physical therapy focuses on mobility, progressive ambulation, transfer techniques, and equipment that's needed for mobility. OT, occupational therapy, emphasizes retaining retraining. They emphasize retraining for skills of daily living, teaching them how to eat and or feed themselves and dress themselves, and how to perform activities daily living, and how to cook again. They involved in all of those things. Occupational therapists are also skilled in cognitive and perceptual evaluation and training, and speech therapy focuses on speech, communication, cognition, and eating abilities. So all is a part of the rehab team. Many of the nursing interventions that is outlined in the nursing care plan for the patient with a stroke, again, it likes to refer you to these care plans, and this is referring us back to 57-1. And a lot of this is the nursing interventions that we're talking about are initiated in the acute phase of care and continues throughout the rehabilitation process. And some of the interventions are independent nursing actions, whereas others involve the entire team. So again, we are looking at the patient's rehabilitation potential, the physical status of the body systems, the presence of any complications caused by stroke or other chronic conditions, and we're looking at the cognitive status of the patient. We are almost done, gang. Y'all have been so patient throughout this COVID-19 coronavirus stuff. I tell you, it's just has turned our world upside down. The rehabilitation nurse, they have to assess the musculoskeletal function of the patient. They assess rehab potential, physical status, complications, cognitive status, family resources. Man, I'm sorry. I don't have that. I have notes and some notes, and I don't have slides, so I just read on to the next slide. But the rehab nurse assesses the patient, caregiver, and family with attention to one, the patient's rehab potential, physical status of all body systems, complications caused by the stroke or other chronic conditions, patient's cognitive status, family resources and support, and expectations of the patient and caregiver related to the rehabilitation program. So now I am on the musculoskeletal function, and it initially emphasized the functions of walking, eating, and toileting, and interventions may advance in a manner of progressive activity. We can see loss of postural stability in this little lady right here. So we have to remember about those phases, because spasticity at this particular phase of stroke denotes progress toward recovery. As improvement continues, small voluntary movement of the hip or shoulder may be accompanied by involuntary movements in the chest of the extremity, and they call it synergy. The final stage of recovery occurs when the patient has voluntary control of isolated muscle groups. So, musculoskeletal interventions that we could do is balance training, transferring from bed to chair, the Bobith method or constraint-induced movement therapy can be used in musculoskeletal rehabilitation. CIMT, that is that constraint-induced movement therapy, is a more recent approach to rehabilitation. The goal of the Bobith approach is to help the patient gain control over patterns of spasticity by inhibiting abnormal reflex patterns. Therapists and nurses use the Bobith approach to encourage normal muscle tone, normal movement, and promotion of bilateral function of the body. Says an example is to have the patient transfer into the wheelchair using the weak or paralyzed side and the stronger side to facilitate more bilateral functioning. Constraint-induced movement therapy, again the CIMT, it encourages the patient to use the weakened extremity by restricting movement of the normal extremity. The ability of patients to comply with this approach is challenging and may be limited in its use. supportive or assistive equipment such as canes, walkers, leg braces may be needed on a short or long-term basis for mobility. And the physical therapist usually selects the most appropriate supportive device or devices to meet individual needs and instruct the patient regarding the use of those devices. They need to incorporate physical therapy activities into the daily routine of the patient. And they need to, they need to sometimes provide additional practice and repetition of those rehabilitation efforts. So they talk about using assistive devices to help them eat. And they get evaluated by, again, PT, OT, speech. All these people are involved. And as it has said several times, this really requires a team approach. So a patient with stroke frequently have constipation, which responds to the following dietary management. So if they have issues, so those are the utensils they come up with, and we're going to move on to elimination and get done with this. So for bowel management, again, you want to control the bowel. You don't want them to get constipated, and you don't want them to be incontinent. So they need to have a diet high in fiber along with adequate fluid intake. And he needs 2,500 to 3,000 mils of fluid daily unless that's contraindicated. Prune juice, or about 4 ounces of prune juice or stewed prunes is something they can have daily to help regulate the bowel or help prevent constipation. Cooked fruit 3 times a day. Cooked vegetables 3 times a day. And whole grain cereal or bread 3 to 5 times a day. Nursing measures are also focused on promoting urinary continence. So, patients that have strokes often exhibit emotional responses that are not appropriate or typical for the situation. Patients may appear apathetic, depressed, fearful, anxious, weepy, frustrated, angry. Some patients exhibit exaggerated mood swings, especially those with the stroke on the left side of the brain where they have the right hemiplegia. The patient may be unable to control emotions and may suddenly burst into tears or laughter. This behavior is out of context and often is unrelated to the underlying emotional state of the patient. So, some interventions for atypical emotional response is to distract the patient, explain to the patient and family that emotional outbursts may occur, maintain a calm environment, and avoid shaming or scolding the patient. We almost done, y'all. We on slide number 105. Thank you, Lord. So, patients with stroke may be coping with many losses, including sensory, intellectual, communicative, functional, role behavior, emotional, social, and vocational losses. The patient caregiver, and family often go through the processes of grief and mourning associated with the losses. Some patients experience long-term depression with symptoms such as anxiety, weight loss, fatigue, poor appetite, and sleep disturbances. The time and energy required to perform previously simple tasks can result in anger and frustration in these patients. So we want to, sorry, let me see something. Okay. Before I go into the sexual function, we have to assist with the coping process. We have to support communication between the patient and family, discuss lifestyle changes from the deficits that they have, and discuss changing roles and responsibilities within the family. We have to, in the process of assisting with coping, we have to be an active listener to allow expression of fear, frustration, and anxiety, include the family in goal planning and prevent and patient care. We want to support family conferences and identify support groups and referrals. It says that this situation can cause resentment from both the patient and family, with a negative cycle of interpersonal dependency and control. Sexual function. Person who has had a stroke may be concerned about loss of sexual function. Common concerns about sexual activity are impotence and occurrence of another stroke during sex. Those are very valid concerns for these people. And that's all I have on my slide. And it does still have a couple of notes that talks about family members having to cope with 3 aspects of the patient behavior. That's recognition of behavioral changes resulting from neurologic deficits that are not changeable, responses to multiple losses both by patient and family, and the third one is behaviors that may have been reinforced during the early stage of stroke has continued dependency. We want to refer them to support groups within the rehab facilities, and those in the community can be helpful. So we do mutual sharing, teaching, coping, and understanding. So it's important to have open communication, information regarding the total effects of the stroke, education regarding stroke treatment, and therapy. All of those are helpful. And again, I mentioned earlier about you may have to do a referral when they having issues. I'm gonna back this up, I'm sorry. When they are having issues related to sex, because many patients are uncomfortable talking about their anxieties and fears regarding sexual function. If the nurse is comfortable and know how to open up the topic, sometimes, and I know, I think it was in the spinal cord presentation that they was giving some kind of ways to have an open ending or a opening statement that can kind of start the conversation off, because it can be a bit uncomfortable. And it says that nursing interventions for sexual activity include teaching about optional positioning of partners, timing for peak energy periods, and patient and partner counseling. And I said before, I know I brought up something about that counseling. And then they talked about community integration. I'm sorry I have to stay on this one slide, but I should have stayed on it all the time. I didn't mean to let y'all look like I'm in prison behind some talking with that little shade on there. I apologize. But it talks about successful community integration following a stroke, that is difficult for the patient because of persistent problems with cognition, coping, physical deficits, and emotional changes that interfere with functioning. Older persons or patients who have had a stroke often have more severe deficits and frequently experience multiple health problems, and failure to continue the rehab regime at home usually results in deterioration and further complications in these people. So community resources can be an asset to patients and their family. And they can talk about the National Stroke Association provides information, resources, referral services, and quarterly newsletters pertaining to stroke. And the American Stroke Association is also a division of the American Heart Association, and they also have information regarding stroke, hypertension, diet, exercise, and assistive devices. This association also sponsors self-help groups in a lot of areas, and they speak about the Easter Seal Society. They provide wheelchairs and other assistive devices for stroke patients. And there are some local groups that can actually offer more daily assistance, like the meals and transportation. So it's really, really important that we hook these people up with resources in the community. And last but not least, we are finally to slide number 114. And I thank you guys for listening. This has truly, truly been something different for me. I have never, ever recorded myself. I did not know how horrible I sound. I hope I don't ever have to do this again. And if I do, I am going to come up with a sexy voice so I can record. So, last but not least, stroke is a significant cause of death and disability. 66% of strokes that require hospitalization occur in adults greater than age 65, and patient, caregiver, and family require ongoing assessment and adaptation to changing needs, because stroke results in a profound disruption in a person's life, especially older people. So we always give special consideration. Y'all probably talking about it in gerontology, but they always have a little spiel at the end related to our elderly and the magnitude of the disability and changes in total function can really leave a patient wondering if they will ever return to their old self, and loss of independence may be a major concern. The ability to perform activities of daily living may require many adaptive changes because of the physical, emotional, perceptual, and cognitive deficits. Home management may be a particular challenge if the patient has an older spouse, caregiver who also has health problems. There may be limited family members, including the adult children, that are living in close proximity that could provide help. The rehabilitative phase, and assisting the older patient to deal with the residual deficits of a stroke, as well as aging, can provide a challenging nursing experience. Patients may become fearful and depressed because they think they may have another attack or die, the fear can become immobilizing and interfere with effective rehabilitation. Changes may occur in the patient-spouse relationship. The dependency resulting from a stroke may be threatening to the relationship. The spouse may also have chronic medical problems that can affect the ability to take care of the stroke survivor. The patient may not want anyone other than the spouse to provide care, which puts a significant burden on the spouse. And last but not least, optimizing quality of life is the ultimate goal with these people. Now, I'm going to leave you with a reflection question. Significant costs are generated in the last 2 years of an older adult's life. How does your position about healthcare resource allocation for care of the older adult influence how you approach their care? Tell me about it on the forum. Thank you.